So, Assalamu alaikum, everyone. Thank you for joining us today. So, we are starting with today's tumor board meeting, and we have two cases. First, we have recurrent pituitary tumor, and after that, we'll be discussing one. Dr. Kamal, are you ready?
Assalamu alaikum, everyone. Yes, I'm here. Is my voice clear?
Yes, Dr. Kamal is clear. Thank you.
Okay, so let's begin with the first case. So my case is of a 32 years old woman who presented with headache, amenorrhea, and increase in size of hands and feet for past 4 years. So this patient presented before as well, 2 years back to us. And can you please move on to the next slide? On examination, her GCS was 15 by 15, and on macroscopic examination, we could see frontal bossing, macroglossia, prognathism. Her hands and feet were grossly enlarged. Surprisingly, the visual acuity was normal, and her fundoscopy is also unremarkable. The ophthalmologist specifically commented that the fundoscopy does not correlate with any pituitary adenoma. Next. The patient initially presented 2 years back, and she was operated in April of 2022 via endonasal transsphenoidal approach. And unfortunately, previous imaging was not available. They said that they have it, but at present they didn't. The patient is currently admitted. The previous biopsy showed pituitary adenoma. Next, please. Her initial IGF levels were also raised. They were around 1300. Current IGF levels are 1168. Rest of the hormonal profile is normal, the early morning cortisol and etc. Rest of it is normal. I have the current scans. Please move to the next slide.
Dr. Kamal, if you want, we have neuroradiologists with us, Dr. Shumaila and Dr. Shayan.
Yeah, sure. She can take over from here.
Assalamualaikum everybody. Assalamualaikum. Okay, so these are CT axial images in which we can appreciate that there is some soft tissue seen in the pre-pontine cistern, and it is more towards left of midline, and appears to be a pituitary lesion, as we have already discussed, keeping in mind the history of the patient as well. We do have the MR images. We can move on to them. So these are axial images, appear to be T1 weighted, and then there is again redemonstration of soft tissue signal intensity lesion in the prepontine cistern, basically in the sellar and suprasellar region. It is showing extension in left cavernous sinus. It is encasing left internal carotid artery, and it appears to be reaching up to the optic chiasma, but I would like to see coronal images for that. On T2, we can appreciate that there is an iso-intense mass lesion in the same location with the same extent. So here we can appreciate that there is a sellar lesion, pituitary lesion basically, because we can't appreciate normal pituitary. Otherwise, it has a suprasellar component. It is reaching and probably pushing the optic chiasma, and these are again T2. This is coronal, this is axial post-cadolinium images. These are showing post-cadolinium enhancement in this lesion. As we already discussed, there is more extension on the left of midline, invading left cavernous sinus. It is displacing the left medial temporal lobe. And can we go to the next slide? Yeah, on the coronal images, we can again appreciate the same. It is making kind of that snowman of figure of 8 appearance on these coronal images. So this is a pituitary macroadenoma, but mostly macroadenomas, they present with visual symptoms or things like that, but this is a functional macroadenoma because we know that there is some extension in the right cavernous sinus, partially encasing right internal carotid artery, completely encasing left internal carotid artery, displacing left medial temporal lobe, pushing optic chiasma. The left half of optic chiasma is not visible, so large pituitary macroadenoma. Yeah, the same findings.
So, Dr. Shayan, would you like to add something?
Nothing much to add. Other than that, like it's showing supracellular extension, and we cannot see the chiasma separate from this lesion, but there is no definite hydrocephalus, not causing any compression effect on the ventricles. And the predominant extension is on the left side, which is grade 4 extension. And other than that, nothing much to add. It's showing very homogeneous enhancement. There's no necrosis within the lesion.
Thank you. So, Dr. Kamal, so the biopsy was so it was only the biopsy was done, or the surgical resection was done previously?
So we proceeded for surgical resection initially, and unfortunately, we do not have those images. The patient presented after 2 years, so some of our attendants are saying that they lost the images. They did have the copy of biopsy, which definitely showed a pituitary adenoma.
Okay.
Oh, actually, she was operated in Karachi somewhere, and she came to us with the again the same tumor. So we did the redo surgery and endoscopically transspinal, and we removed that. After that, the patient was all right, and I remember that the CT scans were quite better, not complete tumor removal, but that was the better. But now she again came with the such of the tumor. So we admitted for the third time, either we can go from the transspinal or the transsalvian. But before that, we need an expert opinion from all the even welcome to Professor Atar Inam, and he's a very senior and very good name in the neuro-oncology. That whether we should go for the again redo surgery, or there should be a radiation therapy or a hormonal therapy. Thank you.
Dr. Athar, please.
Thank you. Thank you for presenting interesting cases. And the cases that you guys bring, it really humbles us. Very complex cases. ये बताइए कि इसका हार्मोनल प्रोफाइल में इनिशियल पार्ट मिस कर गया, वो मुझे लिंक नहीं मिल रहा था. So is it a non-functioning pituitary adenoma?
No, sir, it's a functioning pituitary adenoma.
क्या है इसमें?
So IGF levels are
Oh,
low.
अच्छा IGF levels are अच्छा, ठीक है.
IGF levels are 11 and
Right.
60. The rest of the hormonal profile is normal.
So you know, this is a very these are always complex ones, and they are very difficult to treat, क्योंकि अगर आपने ये ट्रीट कर भी दिया तब भी IGF लेवल कई दफ़ा जो है वो नहीं नीचे होते हैं. सो यहाँ पे दो प्रॉब्लम है. एक तो ये है कि मैस इफेक्ट है, ऑप्टिक नर्व इसकी दब रही है, एंड यू कैन डिसर्न एक्चुअली लिटिल बिट ऑफ द, जैसे इस वाली तस्वीर में राइट साइड पे राइट ऑप्टिक नर्व नज़र आ रही है, लेफ्ट जो है दबी हुई है. तो आई थिंक कि मेडिकल मैनेजमेंट बिकम्स वेरी एक्सपेंसिव. तो सर्जिकल ट्रीटमेंट करके वी शुड थिंक ऑफ रेडियो सर्जरीज. और अभी रेडियो सर्जरी अगर अभी करेंगे तो द ऑप्टिक नर्व इज really not visible या discernible on the left side, so that is going to get damaged. लेकिन अगर सर्जरी करके इतना मास कम कर देते हैं, और कवर्नेस साइनस के बेशक ना करें इतना, लेकिन जो चीज़ ऑप्टिक कैज़म पे जा रही है वो अगर कम हो जाए तो फिर दे कैन सेफली डिलीवर रेडियो सर्जरी टू इट. एंड आई थिंक दैट विल बी, इन माई माइंड दैट विल बी मोर रीजनेबल. अब सर्जिकल इसमें जितना कम कर सके मास उतना अच्छा है. अब वो आप पे डिपेंड करता है कि वेदर यू वुड कंसिडर डूइंग इट ट्रांसक्रेनियली. ट्रांसक्रेनियल अगर करते हैं तो उसमें यू हैव अ बेटर चांस ऑफ एड्रेसिंग द मास इन द कैवर्नस साइनस, क्योंकि इवन एंडोस्कोपिक भी अगर आप करते हैं ट्रांसफेनोइडल विद द कैरोटिड आर्टरी स्टैंडिंग इन देयर, unless you are really and you know a world class expert in transfenoidal and you do nothing else but transfenoidal pituitary, तो कैवर्नस साइनस के में लेटरल पार्ट पे जाके निकालना ट्यूमर will not be an easy task. But if you do go transcranial and you can decrease the achieve a significant cytoreduction, then radio surgery will be the reasonable option. और जो उनको दवाई भी मिल जब तक रेडियो सर्जरी का इफेक्ट आएगा, इनको जो मेडिकल मैनेजमेंट भी जो होगी वो भी जो है रीजनेबल रहेगी in terms of cost effectiveness. Those are my thoughts, sir.
Can I say
Yes, sir.
something?
Dr. Mazhar, please. Yes, sir.
इसमें जैसे डॉक्टर अथर ने कहा रेडियो सर्जरी, लेकिन द साइज ऑफ द ट्यूमर इज प्रीटी बिग एंड आई थिंक इट इज ऑप्टिक नर्व के करीब भी। और तो इसमें ऑप्टिक क्याज्मा का भी, क्योंकि हम जब रेडियो सर्जरी या स्टीरियोटैक्टिक रेडियो सर्जरी करते हैं तो हमारे पास मार्जिन होना चाहिए ताकि जो डोज दी जाती है इट्स अ वेरी वेरी हाई डोज। सो आई वुड रिकमेंड दैट कन्फर्मल रेडियोथेरेपी would be a better option than radio surgery.
ठीक ठीक है। लेकिन वो अगर साइटो रिडक्शन हो जाता है डॉक्टर मदर,
अगर वो हो जाए
हाँ
और
हाँ,
हमारे पास
और सिग्निफिकेंट
ऑप्टिक नर्व
सिग्निफिकेंट
और
छोटा साइज हो जाए,
हाँ, फिर तो किया जा सकता है। as far as we have more than 3 millimeter का हमारे पास होना चाहिए between
गैप
the
होना
tumor
चाहिए। जी
and
हाँ,
the ऊपर जिसका जो है हमारा ऑप्टिक क्याज्मा।
थैंक यू। सो IMRT वर्सेस
यस,
SRS
और
रिडक्शन। ठीक।
और अगर सर्जिकल रिडक्शन नहीं होता तो फिर तो ऑप्शन ही रेडिएशन ही है।
जी हाँ, जी हाँ, फिर तो
डॉक्टर
लेकिन सर्जिकल
मजहर,
रिडक्शन हो जाएगा आई थिंक वो
हाँ, हो जाना चाहिए, हो जाना चाहिए, बिल्कुल बिल्कुल। एंड द फर्स्ट चॉइस शुड बी सर्जरी एनीवे।
जी।
डॉक्टर मजहर,
पहले
फॉर
पहली
आवर
सर्जरी
ओन
जो हुई थी
अंडरस्टैंडिंग,
इसकी, वो भी ट्रांसफेरनल थी क्या, जो कराची में हुई थी?
लास्ट ट्रांसफिनॉइडल थी मेरे ख्याल में।
नहीं नहीं, पहली वाली जो कराची में हुई
पहली
थी।
वाली भी ट्रांससिस्माइडल थी।
अच्छा अच्छा अच्छा, राइट।
जी ऐसा आप
तो
कुछ कह रहे थे मुझसे?
Dr. Ahmed, I just wanted to ask for the participants here, do you measure the distance between the optic chiasma or nerve with the tumor when you're planning whether you're going to go with the radiosurgery or conformation
यस, वी डू एक्चुअली, दैट्स वेरी इंपॉर्टेंट। बिकॉज अगर रेडियो सर्जरी में जो डोजेज हैं वो सुपरसीड कर जाती है फ्रॉम द टॉलरेंस ऑफ ऑप्टिक क्याज्मा, तो अगर एक पेशेंट को हमने डोज देनी है तो वी विल गिव दैट डोज दैट शुड बी विद इन द, बिकॉज ऑप्टिक क्याज्मा इज आवर ऑर्गन एट रिस्क, सो वी डोंट वांट टू डैमेज दैट, सो उसको मेजरमेंट बहुत जरूरी है। तो इट शुड बी मोर देन 2 मिलीमीटर
Okay,
रेडियो सर्जरी के लिए।
more
For
than 2
for external radiation, we don't need measurement, or because our doses are 54 gray, so that is within the
Right.
tolerance of the optic chiasm and the optic nerves.
ठीक, ठीक. Dr. Adnan is also with us. Dr. Adnan, anything you would like to add? I know it's
No, thank you so much, Hassan, for asking the question. But I guess I totally agree with what has already been said. Our role is a little on the backhand, right? In these kind of scenarios, it's solely the surgeons and the radiation oncologists at this time.
okay, sir. Thank you. Dr. Riaz, anything else you would like to ask to the panelists?
These type of the things is that as Dr. Athar said, the medical therapy is very extensive. So for example, we always in the non-secreting tumors or the prolactin mass give the bromocriptine, and they start of the relieving of the symptoms. But unfortunately, we are very much handicapped about the medical management. So again, the thing is that these tumors are difficult to treat by transspinal approach, and when there is a redo surgery, again going through the nose is little bit different. And as the tumor is again progressing, and even there are chances of many comorbidities with these type of the tumors. Transylvian is again such type of the tumors difficult as the carotid is encasing. So managing these cases is always difficult, and the patient is having a full-fledged acromegalic features.
Right. It's quite challenging. Dr. Athar has raised his answer.
जी, so and Dr. Riaz, we don't envy your situation. You always come up with all these challenging cases. Looks like they all come to you. इसमें जो है जो मेडिकल का, वो आई जस्ट वांट टू क्लैरिफाई वन थिंग कि जो प्रोलैक्टिनोमा है, डॉस्टिनेक्स ब्रोमोक्रिप्टिन, दैट इज नॉट दैट एक्सपेंसिव कंपेयर टू थिंग्स लाइक सैंडोस्टैटिन। और जो गाइडलाइन के लिहाज से, इफ इट्स अ प्रोलैक्टिनोमा, इवन इफ इट्स कॉजिंग विजुअल फील्ड डेफिसिट, the treatment of choice is first medical management, which is not that expensive. लेकिन
Yeah.
सैंडोस्टैटिन जो है ना, वो काफ़ी महंगा पड़ जाता है। और तो उसमें आप शुरू तो कर दें, लेकिन सर्जरी तो की तरफ जाना ही पड़ेगा, अदरवाइज दिस विल ड्रेन ऑल द मनी फ्रॉम दैट person's pocket.
Right.
Ehsan, can I मुझे आप थोड़ा सा next case आप बता रहे थे कि PEDS का है ना?
जी सर, जी सर.
तो basically I don't treat PEDS.
Okay.
तो और मेरी एक मीटिंग भी है 9:30 बजे, so can I be excused?
Sure, sir. Thank you so much for joining us, sir. Thank you.
Thank you,
Thank you so much. Thank you so much.
Mazhar, thank you very much.
No,
And
it's a pleasure. It's a pleasure. I always enjoy your meetings.
So just to let you guys know, Dr. Riaz, Dr. Mazhar, Dr. Adnan और नजर आ रहे हैं, शायान सब लोग, डॉक्टर इकबाल खड़ल भी हैं यहाँ पर, राइट? कि जो है वी आर प्लानिंग 5th annual Neuro-Oncology Symposium, which is going to be in August. And जो हम लोगों ने फैसला किया है वो ये किया है कि वी विल डिपेंड ऑन आवर ओन स्ट्रेंथ. हम तंग आ गए हैं बाहर से लोगों को बुला के, एंड वी हैव एनफ स्ट्रेंथ अमंग आवरसेल्फ टू रियली exchange ideas and come up with good plans for the symposia. लेकिन एक जो है वो आ रहे हैं, नौरीन वैसे किसी से बात कर रही हैं, लेकिन नौरीन के एक गेस्ट आ रहे हैं, एरिक बुफे. सो अगर वो आ रहे हैं तो वी विल हैव हिम as one of the guest speakers, but then rest of us it will be all us. हम पाकिस्तान में जितने लोग हैं, जितने एक्सपर्ट्स हैं जो इंटरेस्टेड हैं, तो इसको ध्यान में रखिएगा. डॉक्टर साकिब एंड डॉक्टर हसन एंड द ग्रुप, they will send out the dates to be कि आप लोग इसको ब्लॉक करके रखें. 15 और 16 अगस्त है मेरे ख्याल में. Just want to let you know. Thank you.
Sure.
Thank you so much. Thank you.
सरमद कुछ कहना चाह रहे हैं?
Dr. Athar, thank you. I just have a short question. The way we treat prolactinomas with medical management, and that often recurs to decrease in the size of the tumor, does sandostatin have the same effect on growth hormone secreting adenomas?
Yes.
But it doesn't change the size.
Compared to what? Same effect compared to what?
Like Dostinex decreases the size of a prolactinoma.
Oh, right. हाँ, उतना drastic. So Dostinex पे ना बड़ा drastic effect कईयों पर नजर आता है prolactinomas में, लेकिन sandostatin को उतना नहीं है. Sandostatin more of chemical effect ज़्यादा produce करता है compared to actual the size effect.
Sir, because I was thinking if it reduces it significantly, maybe we could go with
नहीं,
SRS.
वो
it doesn't work like that.
chemical effect ज़्यादा करता है compared to the actually reducing the size.
Thank you, sir.
Yeah. Okay, thank you.
Okay, so we can move to the second case then. And if there is any other question from the participants, they can raise their hands or type in the chat box. We'll be happy to take the questions. So it's the second case. One of our residents is busy in another meeting, so I will be briefly going through this. It's a 14-year-old boy, right-handed, presented with complaint of headaches, vomiting, double vision for the 2 months. And MRI was done this year in Jan. And these are the images. Dr. Shayan, would you like to comment on this?
These are limited T2 axial sections at the level of thalamus, and we in the second row you can see that there's an infiltrative lesion with abnormal signal intensity involving the posteromedial thalamus, and it is also extending into the adjacent cortex of temporal lobe, and resulting in dilatation of the temporal horn. And on T1, it appears hypointense. And on post-contrast, it is showing some heterogeneous nodular patchy enhancement with some areas of necrosis within it. On FLAIR, you can see the extent of the tumor. It appears to be relatively circumscribed, but again, few of the margins are appearing infiltrative. And all right, so considering the age and the location of the lesion, it looks like a midline glioma, and considering the enhancement in necrosis, it appears to be a high-grade pediatric type diffuse glioma, midline glioma.
Thank you, Dr. Shan. Dr. Shumaila, would you like to add?
Ji, Assalamu alaikum. Yes, I agree with Dr. Shayan. There are one to two things which I would like to add. One thing is that it appears that the left temporal horn is kind of entrapped because the left temporal horn is dilated. And the other thing is that if you look at the post-contrast images, the kind of enhancement and there is peripheral nodular enhancement with central areas of necrosis. So in these cases, susceptibility weighted images are quite helpful. So when we see the internal hemorrhages, it goes in favor of, more in favor that it is a high grade, although the baseline images give the same picture, but susceptibility and additional sequences are always helpful. So I would like to request the people, whoever make slides and share their cases, that make it a habit of looking at the diffusion and susceptibility weighted images and add them as a slide in your presentation, because that is going to help you on floor when you will be looking at the images yourself.
So right, so right.
Very
Dr.
good.
Noreen, does it look like it will have stone mutations? Noreen Mushtaq.
डॉक्टर जो midline diffuse midline glioma होते हैं, they are usually associated with the stone mutations and mostly H3K27 mutations. So जो cerebral होते हैं वो H3G3-4R mutated tumors होते हैं. These are the one which K27 muted and with a very bad outcome. Unfortunately, their outcome is not more than 6 months to 1 year. Or वो भी 1 year we are talking about in those kids who have a fully resected disease. Which
Yes, I think Dr. Shumaila ने हाथ खड़ा किया हुआ है. Actually, the reason I wanted to do that is that Noreen is the one who has actually made us more aware of this stone mutations in these midline ones. So when we look at the MRI, even before the biopsy, right? So that's why I wanted to bring it up. Dr. Shumaila कुछ कहना चाह रही है.
Dr. Hassan, if you go back to the coronal flare images, in the right perisylvian location, there is another flare hyperintensity. Yeah, few people can appreciate that. So if I was just going back to the T2 weighted axial images. So if you look at the second first image in second row, there is something lying in the, there's a small nodule which is in this CSF. If you can magnify this, the first image in second row.
The first image in second row.
First image in second row. हाँ, तो आप ये देखें कि यहाँ पे ये पेरिसिल्वियन इसमें लोकेशन में ऐसे लगता है जैसे CSF के बीच में एक नोड्यूल सा पड़ा हुआ है, जो कि मुझे अभी नजर आया है.
किसके हाथ में कंट्रोल जो है?
ये मेरे पास है.
मजाक कर रहा हूं मैं. I know that. आपके हाथ.
जी, दिस वन. आप इसको अगर मैग्नीफाई करके दिखाएं तो आपको लगेगा जैसे इसमें CSF से हट के एक छोटा सा नोड्यूलर सा सिग्नल है, which is other than CSF. And this is glioma. Is it unifocal or multifocal? Because ये एक suspicious सा नोड्यूल लग रहा है मुझे.
You have eyes of a hawk, Dr. Shumaila.
Thank
you. No, really.
मैं डॉक्टर नॉरिंग में चेक कर लेता हूँ इसकी बायोप्सी में But so we did the biopsy only, right? So one of the reasons, discussing this case is, we end up doing mostly biopsy for these lesions. So I like Dr. Athar is here, Dr. Riaz is here, and we have other neurosurgeon recommendations when it comes to the surgical intervention.
We have Dr. Nasir Raza Awan, the top-notch neurosurgeon also here. He can also. Who else is here? Yeah, Nasir, your thoughts?
Assalamu alaikum, Dr. Athar. My apologies, I just wanted to. I've always been wanting to attend these meetings here, but it just so happens I never got a chance to, and I'm really, really happy that I got to join this meeting. इस तरह के सर लो ग्रेड जो हाई ग्रेड जो मल्टीफोकल ग्लायोमास हैं, it's very difficult and very challenging to even diagnose them. जिस तरह भी आपने बताया कि जो ऑन द राइट साइड पेरिसिल्वियन एरिया में भी एक छोटा सा नोड्यूल है. On the first glance, I actually absolutely missed that. और उसके अंदर फिर रिसेक्शन इज अनदर बिग चैलेंज, जिसके अंदर ये रियल लोकेशन इसकी ऐसी है सर्जरी, एंड वी कैन ओनली एंड अप गेटिंग अ स्मॉल चंक ऑफ बायोप्सी. हिस्टोपैथोलॉजिकली इज द ओनली क्या कहना चाहिए लिमिटेशन जो हमें डायग्नोसिस में मिनिमल बायोप्सी के ऊपर मिल सकती है. एंड in the end, there is not much that we can do surgically for these kind of cases. I'm at a loss to tell you कि हमें यहाँ पे radiation और stereotactic radiation कितना help कर सकती है. But this is a very difficult case, very challenging, even for diagnosis from a diagnostic point of view, sir.
Right. Thank you, Dr. Nasir.
तो यहाँ मैं कमेंट देना चाहूंगा
जी,
कि आजकल काफी प्रेजेंटेशंस में ये है कि ट्यूबुलर टाइप ऑफ द सर्जरी इन द ब्रेन. डॉक्टर अतर,
जी,
have you any information regarding the tubular brain surgery?
That is, basically minimally invasive approach, and Asan has also been working on that one. कि आप जो है या तो मिनी रिट्रैक्टर्स लाएं या एक ट्यूब के जरिए जाएं. जो है जो अमीन कसाम ने जो प्रेजेंट किया था, बनाए थे जो, वो भी यही एसएनएस टाइप का है, जो कि ऐसे जाके फिर you get to that point and then you open it up a little bit. But they're all the same. And I think as long as the concept of minimally invasiveness stays, it does not matter whether you use mini retractors or whether you use tubular or whether you do some other gadget. The idea is that with a very small approach, with this very small craniotomy, you get to that point, and it's so deep that even an inch by inch round circle of craniotomy will be good enough to get to that point. And once you're inside the lateral horn, वहाँ से फिर then you can see the tumor very easily. But yeah, I think that's what, as you suggest, that's what we should all try to practice, minimally invasive for these kind of cases. Definitely.
It is helpful, sir. And one of the benefit that you get with the retractor, whether it's tubular or Dr. Athar mentioned, is the brain does not just keep coming in your trajectory in your way to the lesion. So, but the thing is, once you are there, and if we make any damage, then the outcomes are still, challenging. So that's one of the thing. Like, at what cost we are going to, treat. So that's what I think. Dr. Norin wanted to share this.
Actually, Dr. Nasir has his hand.
Nasir has also. Yes, sir, Dr. Nasir.
Gee, the only thing I wanted to add was, yeah, बिल्कुल ठीक है, regardless of what approach, what technique we use to get to the tumor, the problem is the extent of resection. That is in a perithalamic or inothalamic region, जो हमें extent of resection है, we need to be very, very careful about what and where we resect it from. So yes, Dr. Riaz is very right that we need to be minimally invasive in our approach to the tumor, but I think we need to be even more conservative. I remember there was this paper recently regarding intralesional localization of biopsy, whether we take a biopsy from the middle of the tumor or near the periphery, which will yield a better diagnostic tissue. So I think जो हमारे लिए point of consideration है at this point is how much to resect and where to resect from regarding the biopsy. So that's just a little bit.
And another challenge, Dr. Athar and Dr. Riaz and Dr. Nasr also, that one of the challenges that we have is the neuropathology also. For example, if you go for the stereotactic and you take a very small chunk, It happened, it has happened, I think, with many of us. If we send for the frozen, and then the frozen calls you back like, we cannot find out, can you get us a little bit more? And you are in the thalamic glioma, so it's not like you can get
True.
them a little bit more. That's another issue that, the neuro-oncology.
But can I say something, Asan, if you don't mind?
Yes, sir. Yes, sir.
You know, my limited experience is that once you're in that thalamic glioma, for some reason, the difference between the tissue and the normal brain is very distinct in the midline region. And this is a pretty large size. So, I mean, compared to some other infiltrative gliomas, which you see in like cortical and subcortical regions, compared to these thalamic. So I think one can still get a big chunk from here by moving the retractors and, changing the angle a little bit.
So, if I may add, sir, if we get minimally invasive approach with neuronavigation,
Yes.
that probably will be very helpful.
Absolutely.
Yes.
न्यूरो नेविगेशन वैसे कितनी जगह पर है पाकिस्तान में? Do we have an idea at this point?
Sir, I can tell you about Lahore. We have probably at 3 places neuronavigation. Mayo Hospital में है, Sheikh Zayed में है, and of course PINS में है.
अच्छा, ये यहाँ पर है हैदराबाद में डॉक्टर राजा बात करेंगे जिसे वो कराची में तो मेरे ख्याल में 4-5 जगह पे है यहाँ पर भी, राइट? आगा खान, LNH, JPMC में भी है, शायद सिविल में भी है. I'm not wrong.
Dr. Shumaila want to add.
No,
जी, Dr.
it's not in
Shumaila.
JPMC. I think they don't use it. Yes.
है लेकिन यूज नहीं
जी,
करते. हाँ,
जी,
ऐसा
yes,
कुछ
जी.
था, राइट?
Salman, do we have in Peshawar the navigation? I think yes, we have. You did.
सरमद, हाँ.
Sarmad.
Yeah, right. और गंबट में तो है ही है. ये
Yes.
डॉक्टर राजा, हैदराबाद में नेविगेशन है 2-3 अस्पतालों में या एक ही जगह है?
नहीं, हैदराबाद में अभी तक कोई नेविगेशन नहीं.
ओह, अच्छा. So वो डॉक्टर
हम अल्ट्रासाउंड यूज करते हैं.
अल्ट्रासाउंड, लेकिन फिर अल्ट्रासाउंड में बिकम एन इश्यू अगर आप ट्यूबुलर रिट्रैक्टर इस्तेमाल कर रहे हैं. So then you end up using a bigger craniotomy, right, to get the probe in. So yes, Dr. Nasir, I think we have your answer. Dr. Shimal ka haath is up.
Yes. So Dr. Noreen, you want to share something?
Yes. So for the confirmation of the pathology, we have sent the sample across to US, and it is actually a diffuse benign glioma H3K27 mutant tumor. So वही जो अभी हमने बात की कि these tumors are usually have a very poor outcomes. But Dr. Athar वाली बात की अगर आप resect, the only difference comes when there is a good resection. So अगर resection है तो फिर भी ये चल जाएंगे कुछ महीने, साल, शायद 1 साल 2 साल. एंड अगर नहीं है तो फिर ये 6-7 महीने से ज्यादा नहीं सर्वाइव करते. सो जो हमारा छोटा सा डेटा है ऑफ द मिडलाइन ग्लायोमा, उसमें we have 2 or 3 alive बच्चे till 2 to 3 years. बट वो बच्चे थे कि जिनकी रिसेक्शन जो है वो ठीक ठाक हुई थी, और बाकी जितने सारे जिनकी बायोप्सीज हुई थी, none of them survived within, like all of them died within 6 to 7 months. Like a DIPG. So the behavior is like a DIPG.
तो इसमें फिर again, microscope becomes very important, and I wonder if all those centers use microscope. So Dr. Riaz, हैदराबाद में navigation नहीं है, लेकिन microscope इस्तेमाल हो रहा है कि इसमें कि नहीं?
जी, माइक्रोस्कोप है हमारे पास,
तो
इवन प्राइवेट में भी है. और
और आपके ख्याल में अगर हम लूप इस्तेमाल करें डॉक्टर रियाज, तो दैट विल नॉट हैव द सेम वो, है ना?
नहीं, मैंने कभी लूप इस्तेमाल नहीं की है और मुझे उसका कोई एक्सपीरियंस नहीं है.
राइट, क्योंकि उसमें पर लाइट जो ना वो उतनी डीप में जाएगी नहीं. माइक्रोस्कोप में तो बिल्कुल वो अलाइनमेंट होती है ऐसी.
जी सर, मैं सिर्फ यही ऐड करना चाह रहा था कि ये you're absolutely right. लूप में मैग्निफिकेशन तो खैर जो एक इशू है ही है, बट ये इल्यूमिनेशन इज द इशू। लूप में एक तो वो कंसेंट्रिक इल्यूमिनेशन हमें नहीं मिलती है, ऑल्दो देयर आर न्यूअर लूप्स दैट have light right in the middle of the two lenses, so that can kind of compensate for it, लेकिन loop उस तरह का हमें vision नहीं दे सकता। But we in Lahore everybody uses loops there because microscopes हर जगह पे available नहीं है, so we use loops a lot. दूसरा मैंने ये the question I wanted to ask was कि अगर हमें on the right side, if we find a small nodule जो Sylvian Fisher के अंदर है, will we still call it a diffuse midline glioma? Because वो फिर multi nodule वो
multifocal या multicentric
focal हो जाता है जी, multifocal हो जाता
Dr.
है।
Noreen, you're
So
an
will
Yes,
that
expert
Dr.
now.
Noreen is an expert.
So इसमें Dr. Nasir, इसमें there is one query कि if we are so sure that this is actually a metastatic deposit, तो उस पे फिर हम कह सकते हैं, मतलब उसमें भी हमारे पास जो मेन ट्यूमर है, it's basically presented in the midline area. And these mutations analysis will tell us that you look, this is like a big chunk is in the midline area, and it is H3K27 mutant, so it is a midline hybrid glioma with some metastatic deposits. If we are so sure that it is actually a metastatic deposit. So, but generally speaking, in pediatric age group, it's quite uncommon to have metastatic disease in the midline areas, like associated with high-grade midline gliomas. और उसमें ये सारी ये हाँ, अगर आप ये सोचें कि वो किसी जेनेटिक सिंड्रोम के साथ एसोसिएटेड है, तो वी कैन फाइंड मेटास्टैटिक डिपॉजिट और मे बी अदर ट्यूमर्स ऑन सम अदर एरियाज, जैसा जो CMMRD था, and CMMRD is constitutional biallelic mismatch repair syndrome. He had a low-grade glioma in the frontal area and the high-grade glioma in the posterior fossa area at the same time. And then he eventually died with T.
Perfect. Thank you.
Now, I would like to ask if he wants to add something to our discussion, Dr. Nanjabar.
No, I think once again, you guys have already said, especially adults and peds are slightly different. The discussion that is happening, that is really interesting, and I guess nothing else that I would like to add.
Okay. Any other comments, questions from the panelists?
तो इसमें एक चीज और थी, वो अगर आप देखें इसकी रिसेक्शन में and besides the तो ये जा रहा है, so in Dr. Noreen, we have had a series about the extent of resection and survival. Are you aware of any paper about extent of resection and survival in the midline gliomas? If not, then that's what we should probably look into, because अब जैसे इसमें जो है ना, अगर आप थैलेमिक वाला पार्ट कर भी लेंगे, वहाँ कॉर्डेट हेड पे जाने का मतलब ये है कि यू आर गोइंग टू कॉज सिवियर न्यूरोलॉजिकल डेफिसिट, सो वो तो रह ही जाएगा पीछे।
इसमें डॉक्टर सर, वी आर का आउटकम देगा. So generally speaking, the term they used is near total and the maximum debulking. So जितना थोड़ा रह जाएगा उतना ही रेडिएशन जो है उससे वो कवर होगा फॉर सम टाइम. थे जिनको हमने इवेंचुअली 2 साल बाद जब वो प्रोग्रेस किए तो हमने उनको री-रेडिएट किया था. And but unfortunately both of them succumbed like after the second progression उनको हुई. In fact first progression उनको ही, उसके बाद वो 4 महीने से ज्यादा सर्वाइव नहीं कर पाए.
राइट. So इसमें जो है मेनली तो आई मीन
if I may add, sir,
Yes, sir.
Dr. Norman, another question for Fridge here. You can see multiple areas of different intensities. ये inhomogeneity है within the tumor, medially भी है और supralaterally भी है. इसी तरह center जो है core has a different intensity compared to the rest of the tumor. So the point that I raised earlier was depending on where we get the biopsy from, the diagnostic yield will obviously be affected about or based on what area we take a biopsy from. उसके बारे में कोई आप कमेंट करना चाहेंगी क्या representative areas बेहतर कौन से होंगे?
So, Dr. Nasir, जो मेरा experience है, like I'm just talking about my experience, फिलहाल कोई ऐसा data मेरे पास नहीं है. So कि midline glioma में कोई इतना problem हुआ हो टिश्यू का, जो हमारा experience है AKU का in the high grade midline gliomas, उसमें मुझे याद नहीं पड़ता कि कभी भी कोई ऐसा टिश्यू आया हो कि जिसमें हमें कोई representation नहीं मिली हो. Yes, in centers where neuronavigation is not available और जो भी limited resources हैं या problems हैं, तो वहां पर ये problem हो सकती है. Again, इसके अलावा दूसरी problem जो हो सकती है ना, वो ये है कि जो pathologist भी होता है ना, तो उनका भी उस तरह का experience नहीं होता कि वो इस चीज को जो है ना वो identify करे. I think Dr. Athar, can you comment on the representative tissue या कोई इस तरह की चीज पे?
Yeah, I would go for the contrast enhancing part for sure.
Yeah.
And that is, it's delivering itself anyway into the ventricle.
Yes, sir.
Yeah, that's the best part.
So
But
because
we have two hands raised actually
Dr.
now.
Shumaila ने सबसे पहले किया. Dr. Shumaila, you wanted to add something?
I just wanted to add that the scan is from 6 January 2024. So if we get a follow-up, maybe we will be more sure about the second nodule. And whoever is going to get the scan, please ask them to request the radiology to get a 3D T1, because on 3D T1 post-gadolinium images, many a times we see extra lesions which are not seen on axial T1 post-gad or rest of the images. So these are volume-based images and very tiny, especially we experience this in case of metastasis when we are dealing with cyberknife treatment. So 3D T1 post-contrast volume-based images, they always give extra information. And going to give you pathological edema in a good way. Post-gadolinium images are going to show you, because the main lesion, the larger lesion, is enhancing. If it is a metastatic deposit or it's a multifocal lesion, it is going to behave the same way on contrast, the way the larger lesion is. So I think that can be helpful, because definitely anybody who's going to take a biopsy is going to get a follow-up. It's an 8 weeks old scan. Anyone who is going to go and get a biopsy will be needing a new scan. The other thing is that if you go to T2 axial images, the head of caudate appears clear. There are no abnormal signals on T2 axial images. So bilateral head of chordates, they are symmetrical and they appear, there are no abnormal signals in them.
So it's more
I don't think that
it's more in the medial thalamus than actually caudate, right?
Yes.
Yeah.
Dr. Shayan, thank you, Dr. Shumaila. Thank you. That was really helpful.
Well, yes, Dr. Shumaila, thank you for raising your concern regarding this. So I was just going through the previous scans of this patient, and it has been reported at Ahan only. And the previous scans were from 13th of December 2023. So over the period of 20 days, So is my screen visible?
Dr. Riaz,
अभी नहीं हुई. It is showing it will start.
जब तक डॉक्टर रियाज बोल ने क्या कहना चाह रहे थे?
Dr. Riaz, आप कुछ.
मैं बोलूं या पहले डॉक्टर शायान बोले?
So if the screen is not shared, then Dr. Nasir can share this.
No, we can see now your
You
screen.
can see? All right.
Yes, now we can see.
So these are the volumetric images we do in all patients, especially in oncological imaging, and you can see that we can also reformat it and have a better look at the Sylvian region. So this is the Sylvian region, and
यहाँ पर नहीं नहीं थोड़ा सा ऊपर जाइए फिर से जो
जी
और यहाँ पे कहीं पर आ रहा था ना
यहाँ पे कहीं
यहाँ जी
exactly. So I can put them together with
हाँ यही
them
पॉइंट है
so
मेरे
that
ख्याल
you
में
know.
डॉक्टर
जी
आई थिंक आप कॉर्नल पे कर लें क्योंकि फ्लेयर पे हमने कॉर्नल पे पिक किया था तो हमें और
जी
अच्छा नजर आ जाएगा।
वाला ना
राइट
अगर आप खाली फ्लेयर पे देखें शायद तो ये पहले
जी
फ्लेयर पे पेरी सिल्वियन जो सिस्टर ने उसमें प्रोजेक्ट नहीं कर रहा था, लेकिन यहाँ पे ये कॉर्टिकल बेस था, लेकिन जो आपने 6 जनवरी के हमने इमेजेस देखे हैं उसमें मैंने इसको पिक किया है कि ये पेरी सिल्वियन फिशर के अंदर सीएसएफ के अंदर प्रोजेक्ट कर रहा था, विच इट इज नॉट प्रोजेक्टिंग देयर इन द सीएसएफ।
ये भी 6 का ही है। दिस इज स्कैन फ्रॉम 6 जैन ओनली, लेकिन वो चूंकि वो लिमिटेड इमेजेस है ना, सो वी कांट रियली सी के
अच्छा,
वो
प्रॉब्ली
उसके अंदर आ रहा है।
तो इसमें जो आप दिखा रही
इट इज
सैजिटल इसमें
कॉर्टिकल
थोड़ा सा
बेस्ड।
सैजिटल में थोड़ा सा हाइपो इंटेंस
जी
एक मास नजर आ रहा है ये इज द सेम
this
थिंग
thing
जी
exactly.
जी जी अच्छा
So it
अच्छा
is cortical based. It is very low on T1 and not showing any
हम्म
enhancement, and we could not see. So we reported this as a non-specific and wanted a follow-up, just like Dr. Shumala said. But it did not appear suspicious because it did not grow over time, and but the lesion in the thalamic region grew.
इंटरेस्टिंग
Thank you.
So I'll just stop sharing.
Thank you, Dr. Shyam. Dr. Riaz, now you can.
Yes, tumors adjacent to the ventricles always create the problem. When you are try to remove them, there is an opening of the ventricle and the CSF filled with the blood. And the next post-op day, the patient's GCS is not as good as we can remove the tumor without opening of the ventricles. So here, when we are talking about the safe maximum resection, then always the question of removing the maximum tumor safely is again a questionable, because in any case you have to make a tear in the ventricle, or the ventricle can be open, and that can be a problem. And I have an experience of the child with a frontal tumor adjacent to the lateral ventricle. When we remove, we found that the patient's CSF is coming out. So second day, the GCS was not as good as we are removing the tumor. So it is whenever there is a CSF opening from the ventricle, always put an sponge stone, large sponge stone, at the ventricular site with the patty, so that the bleeding should be stopped and should not be enter into the ventricles.
A very good point, Dr. Riaz. Dr. Athar, do you want to add something?
Yeah, I just wanted
Point.
to I will so that's an just a second I'll just call you back in 1 minute. I'm so sorry, meeting 1 minute call करता हूँ आपको मैं. Okay. So the point that I will mention is this, that you're absolutely right. वो बड़ा issue होता है, and if I can add my limited experience in these things, is कि once you get to the ventricle, ये जो है position इसकी head की ऐसे है, तो everything that comes blood जो निकलेगा, that will gravitate down, so it will go into the trigone area and the occipital horn. And the first thing I do is put a cotton balls in there just to block that off. Cotton ball and patty वो सब रख के ना उसको block कर दिया ताकि वहाँ से जो भी blood निकले नीचे ना जाए. उसके बाद then we start to resect the tumor. और जो है उसके बाद जब ट्यूमर रिसेक्शन हो गया, हेमोस्टेसिस हो गई, देन आई रिमूव दोज कॉटन बॉल्स एंड पैटीज जिससे मैंने ब्लॉक किया हुआ था नीचे का पार्ट, ट्राइगोन एंड ऑक्सीपिटल हॉर्न. और उसके बाद जब उसको निकाला तो फिर देन आई झांकी में मार लेता हूँ एक, इधर विद एंडोस्कोप और विद जस्ट माइक्रोस्कोप. एंड मेनी टाइम्स देयर इज बाय दैट टाइम द ब्लड दैट हैड ट्रिकल्ड ऑन हैज ऑलरेडी बिकम अ लोथड़ा, सो दैट कैन बी इजीली सक्ड आउट और रिमूव्ड. और फिर उसके बाद देन पुट अ वेंट्रिकुलोस्टमी इन देयर to make sure that for the next couple of days it clears up. So those are the thing that I do, and I don't know if you guys approve it or not, but that's my practice.
Yes, I think Dr. Riaz also mentions you're putting the sponge stone. I think you so
My
sponge stone
question
में
is-
मुझे ये लगता है Dr. Riaz, and as long as you remove it, that's perfectly fine. But I mean, not leaving it inside, right? Because then it will block and trap the ventricles.
But you were talking about the ventriculostomy. So whenever the ventricles, for example, the ventricles are the part of the ventricle is the temporal horn. How you put the ventricular catheter? Because
तो
it's
उसी से
very
जिससे
small.
जिससे हम गए थे जिससे हम
Okay.
गए थे उसी से जाके डाल दिया और नया नया वेंट्रिकुलोस्टमी नहीं किया
Okay.
उसी से डाल दिया कैथेटर और फिर बाद में उसको पुल कर लिया
ठीक, सही.
2-3 दिन के बाद.
Okay, excellent. So I think we are coming to the end of this session. Excellent discussions, learning points for all of us, and thank you all for joining us today. And you can visit the Pakistan Academy of